Well, thanks for coming. I appreciate everyone coming out, especially my own office staff in the back. We're very supportive of everything we do, and I appreciate that. And so I'm going to talk a little bit about hip fractures, this sort of national challenge and local challenge we have with managing these patients who end up being when they see us with a broken hip, it's a very critical point in their health care, and unfortunately a lot of folks really take a turn for the worse when they have this injury, as much so as if someone has a heart attack or a stroke. And so one of our plans at our place is to give that fact the respect it deserves, and that critical medical situation the level of care, and to have it on everyone's radar that this is not someone who needs to lie around until we find a chance to fix their hip fracture, but this is a really critical moment for them, and we need to get them on a pathway and have a programmed approach so that we can really treat them and move them along and give them a good positive outcome. And we'll talk about a little basic anatomy and stuff, and for me the fun part, fixing the hip fractures, and then we'll move it along to the next crew. There's a lot of information on some of these slides. I might not touch every word on that. But basically, the typical, some of this is maybe a worst case scenario sort of thing, but the typical hip fracture would, come into the hospital, be diagnosed with a hip fracture, be given a Foley catheter, perhaps given some pain meds, we get their x-rays, maybe even putting a little bit of light, gentle, Bucks traction. Admit them to the hospital, have the medical docs see them, and when they were clear and stable for surgery and there was OR time available, we would fix them. And in some institutions, although we've been better than this, in some institutions maybe it was 48, 72 hours or more until the fracture was taken care of. And the problem with this is that none of us want our mother or grandmother or eventually ourselves sitting around for that long in pain before surgery, but also that the health problems associated with that can be extreme. The delirium, the bed sores, pneumonia, and everything that can happen from lying in bed. And patients who lie around longer, in the end, are found to have more medical problems post-operatively or even pre-operatively before surgery. So it's a real initiative on our part to try to intervene before that happens. And of course, the very last part there is that, the worst case scenario, this hip fracture is a terminal event for some of these people. In other words, they have their hip fracture and they end up in a hospice situation, or they don't survive the year. And so we would like to intervene early and appropriately and really change that outcome for some of these patients and families. In the first year after a broken hip, depending on where you Google this, the mortality rates can be 20% or higher. And the ability to go back to an independent lifestyle if they came from an independent lifestyle before, it can be very low. The post-op rates of delirium are high. And there have been centers who have been able to intervene as we're starting to do, and to change some of those rates. And that's really what we're trying to do. And our main goal in this, I would say, is to, we have this patient population that we're taking care of every day, and there's really a way to do it better. And that's what we're doing now and what we're going to continue to be doing.